This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm Teacher LaFredo, and this week, a program to take your breath away. Sorry. I'm coming to you from KRMC Respiratory Services. My guest is Tina Tharp. She is the clinical coordinator for respiratory services. Hey, Tina, welcome.
Hi, how are you today?
I'm doing well, thank you. Thank you for being here with me.
No, thank you for inviting me and putting up with me while we got it all together.
I'm so sorry that I started with that awful pun. It's not a good way to start the program.
No, it was very good, actually.
Let's see, where does this begin? Right, so we've been trading emails for a while, or trading phone calls for a while, and trying to line this up. And it all began for me when you gave a Lunch and Learn presentation called Living with COPD. Was that the title of it?
Yes. And
I thought, honestly, I don't know much about COPD. In talking with you yesterday on the phone, you confirmed that for me. It was about 15 seconds, and I was like, wow, I don't know anything about this. So I'm going to ask you some stupid questions along the way.
No such thing as a stupid question.
Oh, wait. Let's talk about that in 20 minutes, and we'll find out. No, I don't know much, and so teach me about this. COPD, where do we begin? Here. I did some basic research, so let me get you started. You may not know this, but it stands for chronic obstructive pulmonary disease.
Correct.
You do know this. This is a diagnosis that I hadn't really heard of until recent years.
And you wouldn't have, and a lot of people still haven't, because it's come about through research. And it used to be called emphysema and chronic bronchitis. And what we have found through research is that very few people have either one disease or the other. And they used to be considered two separate diseases. Emphysema affects the air sacs in the lungs that are responsible for the exchange of the oxygen and the carbon dioxide. And chronic bronchitis affects the airways. And in that research, they found that very few people displayed one disease or the other. Most people had both. So what they've done is they've taken that and combined that into chronic obstructive pulmonary disease. And then some people also display symptoms of asthma as well along with that. Okay. So that's how it became chronic obstructive pulmonary disease.
So it could be 1, 2, or 3. I mean, COPD is this umbrella term that could be any number of those. Is that right?
Yes. Any combination or chicken soup mixture, if you will.
Got it.
Of those 3.
So will you not really hear physicians diagnosing people with just emphysema anymore? Is that diagnosis changed?
That diagnosis has changed. You'll hear that labeled now as chronic obstructive pulmonary disease.
Right.
And you may hear sometimes some of the older physicians still refer to that because that's what they've used the majority of their careers and their lifetime. So that still may slip out from time to time. Okay. But the technical term for it is still COPD.
Sometimes, like I go to the store, right? And I see an older person with an oxygen tank and seems to be struggling. There's a difficulty there. Is that COPD in 100% of the cases? If you're on a respirator, do you have COPD?
Not necessarily. There's a lot of different lung diseases. That person could have pulmonary fibrosis. That person could have bronchiectasis, which is a disease that breaks down the lung tissue. There's various other diseases that person could have. But COPD, especially in our part of the country and our county, has one of the highest rates of COPD. So the likelihood is that people with lung disease, chronic lung disease here, are going to have COPD.
You said, and this is something I hear, all the time from providers about our high rates of lung disease and COPD. What's that all about?
Well, for starters, we have one of the highest rates of smoking in the country, and smoking is a major contributor for COPD. Right.
Let's talk about smoking, shall we?
The elephant in the room.
Yeah, right. I was talking, this was a while back, I did an interview with Dr. Adam Braze, and he's a thoracic surgeon, and lung cancer is his specialty.
Yes.
And he mentioned to me how he was talking about securing funding for programs and how he tends to, this is his passion, right? But he tends to run into apathy from time to time from others who say, well, this is in 95. If we're not talking about coal miners, then we're talking about people who spent their lifetimes smoking.
Yes.
And it's kind of hard to feel sorry for them because they brought it on themselves. This is what his reflection was, that he runs into that all the time. Does that sound about right?
You do run into a lot of that, but also where they told the truth.
Yeah.
And I think a lot of the lawsuits that we've seen in the past have shown that we weren't necessarily told the truth about the damage that smoking does. And it's not just the tobacco, but all the additives that were put into those cigarettes. And these cigarettes were placed in MREs in World War II.
Yeah.
Soldiers were sold cigarettes at 10 cents a pack.
Right.
We created this problem as a society. These people weren't just given this and said, hey, take it or leave it. We as a society created this problem. We as a society have to fix this problem.
So let me play devil's advocate. I get that when you're talking about the 1940s, right? But let's see, 1980 was 36 years ago. We knew then that smoking wasn't a good choice, right? Didn't we? I mean, what was the literature like at that time?
We did know that. We knew more of that.
Right.
But you still had that attitude carrying over from the elders, from people that they knew and they grew up with.
Right.
It takes time to change those attitudes. It doesn't matter what the scientific research being thrown at those people are, because that's not what they're coming from.
Right.
These people aren't scientists. These people are people with people that they love and they grew up with, and the attitudes and the societal and the cultural norms that they grew up with.
All of those
that
social
has
factors.
Nothing to do with science,
Right.
from their standpoint. So it takes time to change those cultural norms.
Yeah, I get it. How many respiratory therapists do we have here at KRMC?
I want to say 30 to 34.
That sounds like a lot to me. That's really what that suggests is you have a huge caseload. True?
We have a high census for the number of patients and beds we have in the hospital, yes.
Yeah. So how do patients come into contact with you?
We do all of the respiratory therapy, which would be the breathing treatments. Respiratory medications as far as nebulizers, metered dose inhalers, therapies like the aerobica, which is a PEP therapy where it helps to open up those air sacs in the lungs, helps to clear out secretions. We take care of the ventilators in the ICU that allow people to breathe. Lots of different therapies, BiPAPs, CPAPs, many things throughout the hospital.
So are you working with, you're going to inpatient, you're working with the sleep lab? Are you going from...
The respiratory department is working inpatient in the hospital. Sleep lab is a separate department in and of itself that employs sleep techs.
Got it. But do they have a respiratory therapist over there?
No. They employ sleep techs.
Got it. And they can do all of the above?
Yeah, they have their own certifications and such that they use over there.
Got it. Okay. So 30 to 34 of you just to handle the traffic here, the inpatient traffic. That's really remarkable in a hospital that has how many beds?
234 licensed beds.
Yeah.
Our census runs about 180 to 197 in the winter. When the hospital census is that, the respiratory census is between 60 and 70.
Right.
So about 50% of the patients are on therapy services, which is high.
Yeah. And so part of that is an older patient population?
An older patient population, a sicker patient population, more of them with COPD. And when you look at COPD, women with COPD, when they get that, they get sicker and they get sicker faster.
Right. So I'm returning to smoking. And I'm thinking, no, I'm not starting smoking. It's funny, right?
Catch the look on my face.
let me fix that. Well, that's another story, in fact. I've never smoked a cigarette in my life. I think that's kind of a rite of passage for a lot of kids I was going to say for better or for worse. I can't think of the better part of it.
Right.
But it's kind of, at some point in your teens, you sneak away. I never did, and here's why. When I was a kid, I had asthma. I really struggled with it at times. I mean, I was able to kind of run and play sports with my friends. And so it wasn't like I was totally sickly. But there were times where it was bad. And of course, I'm old now, right? So this was when smoking was allowed in restaurants. And you might go out for pizza and then have to go over to the emergency room afterward.
Right.
It was like that. And so it changed a lot for us. So what I'm getting at is I knew what it was like to struggle to breathe.
Correct.
And I thought smoking sounded like the stupidest thing I could imagine.
Correct.
So I never did it. And it's still a wonder to me. And I'm sorry, I don't mean to be like judgment. I'm judging. So but I don't.
But you get teenagers with asthma who do start smoking.
Yeah.
Because of that peer pressure.
Yeah.
And sadly, your lungs develop until you're 25.
I have a friend who is an asthmatic who smokes and is one of these guys who has no intention of quitting. And he'll laugh about it.
Yeah.
He'll be like, no way, right?
Yeah.
So as a respiratory therapist, I'm sure you have some patients here who say as soon as they get out of the hospital, they got to go smoke, right?
Mm-hmm.
So how do you deal with that?
Well, the bad thing is that psychologically you can't force someone to quit.
Of course.
And nicotine is probably the most addictive drug that there is. And what do we give patients in rehab trying to quit heroin?
Yeah, right.
Here, go smoke a cigarette. Really all you can do is educate them about the dangers, and then they have to make that informed choice. Yeah. There's nothing that we can do to force them.
Of course.
They have to reach a point where they're tired of being sick. And hopefully that comes sooner than later.
It's time for a quick break on Focus on Your Health. We'll be back in a moment for more with Tina Tharp from KRMC Respiratory Services. Stick around. And welcome back to Focus on Your Health. I'm TG LaFredo, and this week my guest is Tina Tharp, Clinical Coordinator for KRMC Respiratory Services. My wife's uncle was one of these people who was like, I'm going to smoke until, really,
Yeah.
if he had been as dedicated to baseball, he would have been Ty Cobb,
Yeah.
right? He was like this. And they had to remove part of his lung. And he was near the end. And the doctor said, you've got 3 weeks to live. And he said, I've got 3 weeks to smoke.
Oh, my
and
goodness.
it was like that, right?
Uh-huh.
And you really appreciate the power that addiction has on people.
Right. But it's the only drug that we don't treat that's as that type of an addictive drug as a society. We have rehab for heroin, methamphetamines, crack cocaine. We treat all of those things in that fashion. But when you look at smoking cessation, it's not treated in the same fashion. It's telephone programs, which, they're great. Arizona has Ashline, which is free. People can use this program. It's over-the-phone counseling. They help people with access to medications, to patches, to gum, the things that they need. But we don't treat it with the same seriousness, in my opinion, that we treat a lot of the other illegal drugs, and it's more addictive.
Yeah. Okay, so we're talking about living with COPD.
Yes.
How do you live with COPD?
Well, you get help to learn how to make life easier. And that's one of the things that we do in Better Breathers is we learn techniques. And Better Breathers is a support group / class that was started by the American Lung Association. And through different community facilitators like myself, we hold classes once a month. And you can come out and we learn different things to make life easier. So 1 month we might learn exercises on how to conserve breath. 1 month we did laughter yoga, which is just a fun exercise to help strengthen your lungs. So we do different things every month, and you just have to learn how to strengthen your lungs. You have to learn that exercise is golden, because the more that you can keep moving, the more that you can keep exercising, the higher the quality of life that you're going to have. And depression plays a huge role in COPD. People tend to get short of breath, so they sit on the couch or they sit in their chair, and then they get more short of breath, and then they drop more out of life. And as those things go on, they get more and more depressed, and so they drop more and more out of life. And it's a vicious cycle that happens in their lives, and they disconnect from their friends and they disconnect from their families. So the real key to living with COPD is to stay connected, to keep moving, and to learn how to breathe properly. And that's what we teach through classes like Better Breathers.
And so initially when someone comes in for the first time, is that a difficult sell? I mean, do people realize they can actually increase their lung function, or do they feel like it's just something they're stuck with?
It kind of depends on where they're diagnosed or how long they've had it before you can actually make that connection with them. The bad thing about COPD is that the majority of people aren't diagnosed until they're in stage 2, because the majority of people don't have symptoms in stage 1. Your lungs are Houdini, and they will compensate and compensate and compensate and fool you until you reach stage 2. So a lot of people have that denial in the beginning that there isn't much wrong. And so they'll push that back and push that back. That's hard to fight against. So you've got to reach somebody when they're open. And if you can reach somebody when they're open and get to them where that point where they're willing to let you in and to work with you, then that's the best time to be able to do that. And you can reach them and get them to start creating the habits of exercise, creating the habits of energy and breath conservation that allows them to stay active. Because as you know, with having asthma, the biggest enemy that you have is anxiety. When you start to feel that breathlessness,
That's right.
When you start to have that attack, you get short of breath, then you get anxious. The anxiety makes you not breathe properly. You get more short of breath from that, so you get more anxious, and it just keeps going and going and going. So you have to break that cycle. And not just with a rescue inhaler, but through calming yourself down. And that's something that we also teach with Better Breathers. So you have to engage people in those kind of techniques.
This is something I learned as a kid when I was diagnosed with asthma, and that if I could slow down and, slow down and try to rein it in instead of because when you can't breathe, you start to freak out.
Yes.
That's how it goes.
And that's normal.
Right?
It's 100% normal.
It's only going to get worse.
Yes.
And so then when I started to learn that, okay, if I pull back a little bit and I can actually, and then I started thinking, well, does that mean that asthma is all in my head? What is, because it's...
But it doesn't.
Right.
It's just that you have this anxiety that comes along with that,
yeah.
Because breath is life.
Right.
And that's your body's fight or flight response saying, oh my gosh, we have to do something. But we have to overcome that, and we have to calm down. And we teach pursed lip breathing, which I like to call, and people laugh at me, but sniffing the roses and kissing the fish, because we all have to kiss some fish, face it, to get through life.
Okay, I'm picturing it.
And we all need to sniff the roses from time to time, right?
Yeah.
So, if you breathe in through your nose and blow out through your lips,
right,
while making fishy lips, and you need to breathe in 1, 2, and breathe out 1, 2, 3, 4. So you need to breathe out twice as long as you breathe in.
Ooh.
Because what you're doing is you're expelling that trapped air that's getting trapped because you're having those bronchospasms. So you've got airways that are closing down. They're trapping the air that you're bringing in. It's making each successive breath harder to take. So if we slow down, we can slow down the trapping a little bit until we can get to the medication that we need to help to open those airways back up.
Got it.
And if we can overcome that, then we help ourselves in that attack. We make it a little bit better. We learn those techniques in Better Breathers. And by exercising, we strengthen the muscles around our lungs so that we're able to do that a little bit better. It's a whole cycle that we have to learn. And the earlier we can get to people, the better we can learn it. But even people who have had chronic lung disease or COPD for years can learn these techniques. I know a lady through Better Breathers that she would get short of breath with making her bed. Through learning pursed lip breathing, she can now make her entire bed and not have to stop.
Yeah.
I mean, that's a triumph.
That's right.
That's a victory for somebody.
I mean, it's a quality of life factor.
Exactly.
Right.
You can now go out and enjoy the things that you want to do. You can go out and spend time with the grandkids. We have a splash pad being built here in town. That's a goal.
Yeah.
To be able to take the grandkids out to the splash pad. And that's all we want. We want to be able to teach people techniques to give them back their lives.
Yeah.
And I actually have a program that's very visual through the American Lung Association that is a virtual bronchoscopy. A bronchoscopy is where we take a camera and we go down into the lungs and we look at the lungs. And through this program, I can actually simulate what happens during a bronchospasm.
Okay.
And I can simulate what happens during the different stages of COPD as COPD worsens. And people can see what's going on in their lungs. And I think it helps to bring home the disease and what is happening, and that it's not all in our head, that it is in our lungs. But the program also has another aspect where it shows what happens when we're exercising and how quickly that air trapping builds up. So it can show the difference in what we can do if we use the proper techniques to alleviate some of that.
Yeah.
So I think it makes a big difference for people because it brings it back into focus for them, if that makes sense.
It does make sense. And we aren't used to visual representations of those sorts of things. This is all what's going on inside of you.
Right, because we don't get to see. The doctors get to look in there and see, but we don't get to look in there and see. And I think for patients, I always feel bad when patients break down and cry when they watch the presentation. But I think it's because they finally have an answer. They finally know for sure what is going on. And I think that's very powerful for them because I think that gives them what they need to finally say, okay, I have to do something about this.
Yeah. We talked about, you mentioned the first and second stages of COPD.
Yes.
And you wouldn't necessarily know what's going on in stage 1. What are some of the symptoms?
Shortness of breath. Just because we get older doesn't mean we have to be short of breath. That's a fallacy.
Okay.
So when you're having shortness of breath and you're doing the activities that you normally do, and now all of a sudden you're starting to get short of breath. If we're having a windy day and you're starting to cough from that windy day, pain in your back that's not related to an injury or anything like that, it's just kind of mysterious. Tightness when you're breathing, those kind of things. And I can't stress how much people really think that because they get older that they have to be short of breath when they do things.
They're just stuck with that.
And you really don't.
Yeah. Right.
It's not necessary. So a cough. Anybody over the age of 40 who's ever smoked should come in and have what we call a pulmonary function test.
Yeah.
Anybody over 60, but then also anybody at any age with a chronic cough, excessive mucus production, shortness of breath with just a little bit of activity, and any kind of wheezing, which is that high-pitched sound coming from the lungs.
Oh, yeah. I know it well. In fact, that's just part 1 of my interview with Tina Tharp of KRMC Respiratory Services. Join us next time for the second half of our conversation about living with COPD and respiratory health. You can reach KRMC Respiratory Services at 928-681-8555. That's 681-8555. Also during the program, we mentioned the Arizona Smokers Helpline, also known as the ASH Line. You can find out more about that program at ashline.org, or you can call 800-556-6222. That's 800-556-6222. I'm TG LaFredo, and if you'd like to get in touch with me, you can send me an email at foyhradio@gmail.com. That's Focus on Your Health, foyhradio@gmail.com. Thanks for listening, and we'll catch you next time.